Hello and welcome everyone. Donation after brain death is something which we all know, but donation after circulatory death is something which is not something most of the people are aware about. So we'll look at its controversies, the attitudes, and the evolving role of the regional perfusion technology in this. We'll be addressing the technical tensions and how to maximize the organ donor pool over here. So how much organ shortage we have? Only 10% of the donors need is met. Solid organ transplant met only 10% of the total donor needs. This is the data coming out in 2017. So there is a 90% unmet demand for transplants, so which attributes to a significant mortality among patients on wait list. Now this list is probably going to go more bigger because the population is aging and there are more lifestyle diseases resulting in more demand for organ transplant. So the circulatory death donor is an increasing vital pathway to maximize the potential donor pool beyond what we conventionally know. So the ethical integrity and the success of the DCD programs hinges critically on the ICU professionals because they are the ones who will be at the bedside when this particular thing is happening. So what exactly is this? It is the donation after circulatory death involving retrieval of organs from transplantation following death, which is confirmed by the circulatory criteria, that is permanent absence of respiration and circulation. Now the rates have increased more rapidly than the brain death rates, often yielding favorable transplant outcomes. In lung transplantation, DCD utilization rose from 1.1% to as high as 4.2%. So there is a classification called the Maastricht classification of donation following cardiac circulatory death. DCD is characterized based on the circumstances of the death with varying warm ischemia times and the control levels. So in this, the first is found dead unwitnessed, which is out of the hospital. This is basically uncontrolled type, and the warm ischemia time will be approximate. We can't be very sure about it. Again, witnessed cardiac arrest in and out of the hospital, both areas it can happen. It is uncontrolled type, and again the warm ischemia time will be approx. Regarding the withdrawal of life support therapy, this has to be in hospital. It is controlled, and we do know the warm ischemia time. Regarding the cardiac arrest after brainstem death, this can happen in hospital again, which is controlled, and we do know the warm ischemia time. The next we have medical assistance in dying and the voluntary assisted death. This is again something not present in all countries, but this can happen, and it essentially is not something we have in most of the places. But if we do have, then we know the details of this case. Regarding controlled versus uncontrolled, controlled means that it takes place within minutes after death is pronounced following a planned withdrawal of life-sustaining therapies. This is 3 and 4. Uncontrolled, as we have seen, it is the total opposite of it, where we are not very sure about the warm ischemia time. So many healthcare professionals express unease with the category 5 processes. So this we have already discussed. This has a lot of other ethical issues. We will not go into the details of this. Regarding the evolution of organ preservation, the objective is to minimize ischemic injury suffered by the organs after the circulation has stopped. This is very important. So in situ cold perfusion is important. Cold perfusion is flushed into the femoral artery, localizing perfusion to the abdominal organs, and it is limited to uncontrolled states where there is uncontrolled donation following cardiac death, or there is super rapid retrieval, rapid laparotomy with immediate close flushing before organ recovery is used in again the controlled scenarios. Normothermic regional perfusion, this is advanced therapy using warm oxygenated blood to the organs in situ. It is evidence-based with improved outcome. So basically, in case of uncontrolled, you immediately try to do it because we are uncertain about the warm ischemia time. We try to make sure that we preserve the organs. So you put flush into the femoral artery. For rapid retrieval, where we have control, you can, after the death, you can directly take the patient to the OT and do the flushing of the organs. And the other part is normothermic regional perfusion, where you try to maintain the perfusion of those organs which you want to retrieve. Regarding normothermic, how it works. Normothermic uses extracorporeal circulation to supply warm oxygenated blood to the organs in situ, post-mortem, ameliorating the ischemic effects. So you have something called the abdominal NRP and you have something called the thoracoabdominal NRP. Regarding the NRP, the evidence is that there is increased organ utilization. Studies report significant higher organ utilization following the NRP, improved functionality, operational flexibility, and ex situ technologies, while ethically less problematic, involve significant expenses. So that must be kept in mind. Regarding the dead donor rule, organs should not be harvested before the declaration of death. This is very important. Concerns exist regarding permanent determination of death, especially the required duration of circulatory cessation. How long should we wait before we declare that the patient is dead? Physicians may question if 5-minute observation period after asystole is sufficient to conclusively determine death. Now there are some ethical tensions over here, mind this. There is something called the separation principle. The conflict here is that the ethical concerns center around the potential of conflict of interest between the decision to withdraw the life-sustaining therapy and the pursuit of the organ donation. So there is a conflict. The same person is doing the both things. He's also withdrawing the life-sustaining therapy and is also pursuing for the organ donation. So the guidelines, the professional guidelines emphasize that the decision to withdraw the life support must be prior to and independently done. Do not do it along with the process of organ donation. Do it prior. After that has been decided, there must be entirely separate meeting with separate set of people. Regarding antemortem interventions, procedures performed before death must be ethically justified, balancing the benefit to the recipient against potential harm to the patient. You have to be good to both the recipient as well as the donor. Antemortem cannulation, insertion of cannula before death declaration, heparin administration, ethical justification mostly demonstrate clear benefit without causing distress. And the language definitely matters, especially in NRP, the resuscitation or reanimation when discussing NRP procedures, in situ tissue perfusion or dynamic in situ organ assessment must be used, because try to understand, we are trying to focus on those specific organs, not the whole person. We cannot keep that person alive. Professional must be careful how they introduce it to the family and colleagues. Terminology, the choices, they impact the perception and acceptance. They must understand that the patient is going to die. What we are trying to retrieve are the organs. We cannot keep the patient alive no matter what. Now, end-of-life care interference, a significant challenge is in balancing the compassionate end-of-life care with these procedures and perceived urgency of the organ retrieval. Clinicians report that the DCD processes can disrupt the usual palliative care practices, leading to discomfort. The possibility of a potential DCD donor not expiring within the acceptable time frame creates distress for the family and as well as a lot of complexity for the staff. So the moral distress for the ICU professional is that there is a role conflict, because you are doing both. You have a donor interest, you have the patient's own interest, the staff's demand, it requires logistic burdens, the futility of care, doing so much aggression at the terminal stages, and poor communication and conflicting care plans can be a major problem over here. Regarding the support, ICU physicians believe that they should help potential DCD donors, at least 72%. ICU nurses, it's around 74%. 14.5% they feel there is a role conflict. ICU health professionals generally support DCD, but as we have seen, challenges remain because there are some people who think that there is a discrepancy. Regarding the nurse physician's demand, this disparity suggests that the nurses value the meaning derived from donation, fulfilling the wishes of the family and closure more highly than the end of life experience than the physicians, who may focus more on the clinical aspects. Knowledge deficit is a major problem because there is a lack of knowledge in most of the people regarding the classification. The solutions is more education for the doctors as well as the nursing staff. There are some systemic barriers like lack of standardization. There are no clear guidelines, no standardization. There is definitive training deficit. There is a resource strain, especially in the last stages. There is, of course, interprofessional conflicts. There will be team conflicts, poor communication with family members. Everything can happen. Regarding the legislative framework, there are opt-in systems where the explicit consent is required and opt-out where the presumed consent unless explicitly refused. So this will vary from the country to country. And the strategy is to have a clear protocol, a national regulatory framework for each country, institutional protocols to how to implement those guidelines, and all the stakeholders must be engaged. There must be interprofessional education, as we have already discussed. There are practical aspects, there are the philosophical aspects which must be addressed. Managing the moral distress is important. Always ask, try to recognize the distress the person is suffering from, affirm the distress, assess it, and then act on it. This is very important. The 4 A's, how to address the moral distress in DCD contexts. Then you have the 4 R's, that is the recognizing the complexity in DCD, to go about and change the situation, release, reconsider, and restart. So you recognize the problem, try to analyze it, reconsider the perspective, and then maybe try to explain it again in a proper manner. So you need specialized staff for that, you need support system for that. So the path forward is DCD is essential because we definitely have a lot less organs than we want for transplant. Technological advances like NRP is important, but it has got ethical problems with it. The human element should never be forgotten over here. The ICU staff, the patient, the family, everything must be considered ethically and the barriers must be addressed. So you must have clear protocol, continuous education, robust institutional and national policies to